So thank you for the introduction. Quite a long job title, but actually gets longer. So as well as my regional role as the Chief Digital Officer for the North East and North Cumbrian developing integrated care system, I'm also the Chief Information and Technology Officer for North Tees and Hartlepool NHS Foundation Trust, which was one of the Department of Health demonstrator sites a number of years ago. So very proud to represent both of those organisations. And my role, I guess, from an organisation and a system level is a bit like building a bridge from both sides of the river. What we wanted to do is actually meet in the middle. Otherwise, we'll end up with two bridges, which is quite costly and no good for anybody. So a little bit of background to the Trust. Quite a small to medium-sized organisation covering a large part of the southern part of the North East. We have 3 sites within our organisational structure. The University Hospital of North Tees, which is the major site, covers most of our clinical services. We have a smaller site at the University Hospital in Hartlepool, which is predominantly a cold site that manages all of our elective care, a comment that was made earlier this morning, and a community site in Peterlee. Collectively, they're all connected together electronically and digitally, and all share the same aspirations and ambitions. And we employ just over 5,500 staff. We're covering a population of 400,000 citizens, turnover about 275 million per annum. We are very proud that we are a global digital exemplar fast follower. The interesting comment there that we're actually following the Royal Liverpool and Broad Green Trust on the opposite side of the country. And our tenuous link there is the commonality of our electronic patient record system, InterSystems, Track Care. And I noticed that Track Care, or certainly InterSystems, have been mentioned a couple of times over the last day. And we are really involved and engaged in some of the developments that InterSystems are bringing to the market. But as well as our GDE badge of honour, we're also a CQC good organisation, up in that 66% that was mentioned this morning. Really proud of that, but good isn't good enough. We are now on a journey to outstanding. We want to be as good as we can be, and that journey is about bringing people along with us. We do have quite a track record of innovation and transformation using technology. And it was interesting listening to Lord David Pryor this morning. Our organisation is set within those industrial wastelands of Teesside. In fact, my former career was an engineer in the chemical industry on Teesside, so I've actually got some of the experience from that background that I've brought into the NHS. So much so that when I joined North Tees and Hartlepool in my first incarnation back in 2004, in all honesty, it was like stepping back into the dark ages from a technology point of view. We didn't routinely have access to Wi-Fi. Clinicians were walking around with clipboards and not much technology. So we were really trying to push the boundaries of technology at that time. And we introduced Wi-Fi in our A&E department, mobile computers on wheels to allow people to move around in an agile way. I'm proud to say that we were one of the organisations that introduced technology as a consequence of the National Programme for IT. So we introduced picture archiving and communications, A&E systems, maternity systems, and so on. And at that time, we were also digitising paper-based records for the future. Step forward into 2009, we then started to look at how we consolidated our internal infrastructure and started to look at an electronic patient record system as the bedrock on which everything else could be built. Excuse me. We also introduced digital requests and order communications, again, quite early in the journey. We implemented a region-wide image sharing platform called the Image Exchange Portal that allowed the 8 acute trusts in the region to share images in real time to allow diagnostic services to be improved. So quite leading edge at that time. In 2016, I came back from the wilderness. I had a spell at the Strategic Health Authority and then a spell in NHS England, but the magnetic pull of the Trust brought me back to Teesside. And we were then about 9 months into our go live of our EPR implementation. And there was a Freudian slip there, but there were some problems. And those problems were not so much about technology, it was about process and people. So I had quite a task on my hands to resolve some of those things. But I am pleased to say within a very short space of time, we did that. And now we are literally cooking on gas. We've rolled out all of our clinical systems. Our most recent developments have been the implementation of electronic prescriptions, medicines administration, theatres, and so on. We've now recently completely removed all paper from our A&E and urgent care departments and have moved to a purely digital way of working. Our next journey will be around rolling out at scale our internally developed Scan for Safety product called CareScan Plus. That will complement our program of work as part of our global digital exemplar program called the Digital Hospital of Things, and really bringing everybody along in that journey and then integrating to the broader health and care system around the region. We've described all of that in our digital roadmap. Access the North Tees and Hartlepool website and read it at your leisure. In terms of our direction of travel, there's been this opportunity set that we'll remove paper from the NHS by 2020, and I think that deadline has now moved to 2024. In my humble opinion, we will never remove all paper. I think we'll need to have some paper on occasions for when the computers don't work, and believe me, they won't work on occasions, so you need a bit of a business continuity plan. The other thing to consider is in a world where we become more digitally dependent, there are people out there that want to do harm to the health and care system. So bear that in mind when you're designing and developing systems. As well as standardization, consider security by design, not by exception. So our Digital Hospital of Things is quite a simple endeavor. It's about getting the basics right. Consider the infrastructure that we need to embed within our organizations. In a hospital that's 50 years old, it was never designed to have Wi-Fi across the organization. So you need to think about those things. Work out where the plumbing needs to be. Work out how you make sure that those systems that you add into the infrastructure will work time and time again reliably. So safety and standardization is at the heart of everything we do. You then can build your applications and your services. You can provide services to the patients to allow them to self-manage where necessary and appropriate. Most importantly, build safety around the applications that you're going to roll out at scale and pace. Secondly, think about how your organization becomes part of the broader health and care infrastructure within your locality. They are the basic building blocks. And without doing that, we need to make sure that people understand what it's all about. One of the ways we can gauge and measure, and it is a method of standardization, is how we compare with the brightest and the best. So recently, we've been very fortunate to have the acclamation of being one of the more digitally mature organizations in the NHS in England. So I think we are joint first using the Clinical Digital Maturity Index. But that's really a self-declaration of our assessment. And if we really want to compare ourselves with international partners, we need to use something such as the HIMSS methodology that we can get equity across all of our provision and understanding. And therefore, we can truly measure ourselves against the brightest and the best in the world. And again, my view here would be that we will only be as good as the weakest link. Once we start to join organizations together, and the way that we need to work, we don't just move patients around the system these days to get the best care where that can be delivered. Clinicians will equally need to move around if we want to get the biggest bang for the buck. And clinicians don't want to work on one system one day and a different system on another day, because that in itself will introduce risk and error. So we need to consider how we think about those things and converge those systems using ideas such as clinician passports. Our journey on the GS1 trail started with the announcement of the e-procurement strategy. North Tees and Hartlepool then got engaged in about 2016, started the Scan for Safety program. We started to consider at that point what systems and services were available in the market. And from that, very quickly, we decided to think about our own requirements. We were accredited, like a couple of other colleagues have mentioned earlier, in 2018, and now we are rolling out our systems, our CareScan product, to all inpatient wards and theatres, a very aggressive timeline over the next 9 months. I'm going to focus on these two things for the next few slides. One of the challenges that I think we all face as technologists within health is we don't really know the problems that we're trying to fix. And it's really incumbent on our clinical leaders and their support staff to describe those problems. Then technologists can find the solutions to those problems. Often we use the wrong tool for the wrong purpose, and this is really where we need to work hand in glove with those clinical leaders. So, as I've already mentioned, when we started this journey, we looked at what systems were available. That was then, this is now. Everybody's matured, everyone's starting to develop stuff, but we felt that we needed to consider the requirements of our clinical leaders and how this would enhance their workflow and their ways of working internally. So we needed to make sure that whatever we developed, it would be adopted. You can have the best system in the world, but if it's not being used, you may as well not have it. So we wondered what we could produce ourselves. We went back to the drawing board. We came up with quite a rigorous outline of the things that people wanted. We wanted to consider the process and the workflow rather than just the technology, but fundamentally how people, process, and technology would align to develop the outcomes that we needed. This was a quote, I believe, by either Matthew Swindells or Will Smart, but in summary, if we make things difficult for clinicians, they won't use it. If it's 400 mouse clicks or 17 logins to get into a system, they'll find a workaround. So our technologies need to be a utility, something that's simple as putting your beans in the tin or taking them out of the tin, putting them in the microwave, and it will heat up every time and time again. So keep it simple. We wanted our systems and our process and our products to be clinically owned and continually developed and improved. We wanted to be simple, practical, and available. We wanted to make sure that it would help the process of adoption and sustainability across our workforce. And they were the key design principles that we built in. We didn't want everybody to have literally the Batman utility belt. We needed one product, one tool for one purpose that then could be used for many other purposes. Fix it once, solve many problems. It does help when you get a mandate. Quite often, if we just let things drift, we don't get very far. So it's helpful that the Department of Health wanted to mandate this for the purposes of patient safety, for the standardization of clinical practice, removing that unwarranted variation. We need to integrate whatever we do with our single version of the truth, the electronic patient record. There will be additional benefits, such as inventory management, but that will be a byproduct of point-of-care scanning for the purposes of safety and accountability. Then ultimately, how we can then prove that, but also share best practice where that's appropriate and necessary. We wanted to identify people, which includes patients and staff, making sure that we can use our tool and technology for the purposes of training and prevention of error. My firm belief is we don't want to keep looking back. We want to prevent things from happening in the first place, and that was one of the key design principles of our product. Reporting is great, but we want to predict into the future. So by capturing this data en masse, in the future we can use things like machine learning and AI to assess our data that we've collected and improve the workflows and purposes that we're there to deliver. It is designed by the NHS. It will be available for other organisations. We're starting now, as part of my regional role, to develop and share the best practice within North Tees and Hartlepool against our neighbouring organisations. Quite difficult, because if it's not invented in their backyard, quite often people don't want to use it. So we need a complete different mindset, a change in our culture to help this work for the system. One of the reasons that IT projects fail is because they're called IT projects, National Programme for IT, a case in point. So we need to focus on enabling transformation, improving patient care and the deliverables. And the way we do that is we enable the clinicians to make that difference. So our approach is about getting clinicians to lead this agenda. It's also about creating a vision, having standardised ways of working described in a method, and getting an agreement with the clinicians and the enablers in the form of a compact. We will give you this, and in return, you will give us something back. One example of that is quite often the technology doesn't work. So tell me why the technology doesn't work. Because I forgot my password. Well, that's actually called a picnic problem. Problem in chair, not in computer. People have to share and have to be willing to take some personal responsibility. So interestingly, my recent strapline is www. And that means work with the willing. Those are the people that will sell this, that will make this work if we get them on board early. Clinicians are absolutely integral into everything we're doing, be it our quality care commission ratings, our global digital exemplar program, and everything in between. We work in a health and care system. They are the people that need to drive the adoption and the transformation. Last slide, you'll be pleased to know. So this links absolutely with our global digital exemplar program. It is all about sharing the knowledge and the learning across our communities, but where appropriate, everywhere else. We're not precious. We want to share what we do well, and in return, we want to learn from what others are doing. Fundamentally, it's not just about the technology. People and process in equal measure will transform the health and care system that we're all proud of. Thank you.
We've got a question just here, please.
Hello, Graham. Siobhan Duggan, GS1 Ireland. Great presentation, and you've done fantastic work. You touched on the fact that not invented in my backyard. So, I mean, in Ireland, if one hospital is doing something great, the others don't necessarily want to follow what or be told what to do. So how do you plan to get adoption across the other sides that mightn't necessarily have the level of maturity or standardisation that you've already demonstrated?
So I think the first thing, in the absence of a mandate, is to compare. So something like digital maturity may be a barometer that we can use, but also evidence. So if you can demonstrate that what you're doing is making a real difference to efficiency, effectiveness, most importantly, patient safety, it's very difficult to argue that that's not the right thing to do. Fundamentally, this is about hearts and minds. You know, I think what we try to do in health and care in the transformation space is about 10% technology and 90% culture. We've got to change the culture. We cannot afford, at 71 years old, to work the way that the NHS did in 1948. We've got to transform this, and one of the opportunities is technology, but also sharing the good stuff and learning from the bad stuff.
Okay, thank you for your question, and thank you, Graham, and also thank you, Nick and Ian, for your presentations too.
Thank you.